move on with the next topic. Kalantar-Zadeh will give us his practical approach to dealing with protein energy wasting or malnutrition. He has introduced himself already, so please come. We're looking forward to your presentation.
Thank you. Thank you. Such a great honor to continue with this with this session, especially after such a great debate between between two great colleagues, Professor Kanude and Professor Kuman. I just noticed I don't have, actually here. So there are good news and bad news. Start with the bad news is that you guys don't have lunch break. So please know that you are supposed to be sitting here until 2 p.m., which is very unusual for the United States. Reminds me of Spain. Usually lunch starts at 2 or 3 p.m., but we're going to try Spanish model today. So for those who are still here. And the good news is that I'm going to be done in 30 minutes, in 25 minutes hopefully, and each slide will be shown to you 20 seconds. So you have 20 seconds to look at the slide, and if you look at your text in 20 seconds, the slide is gone, 1 or 2 slides. Okay, so let's start here. So this is gonna be 20 seconds. No, we don't need to actually last so long. I'm going to read the objectives to examine pathophysiology and clinical implications of protein energy, I'm sorry for the misspelling, wasting, sarcopenia, cachexia, and malnutrition, to review screen tools for that, and then to discuss role of serum albumin and others, with focus on dialysis patients. Why? Because malnutrition is more relevant in dialysis as compared to pre-dialysis or non-dialysis CKD, at least in earlier stages. So for those who would like to come back to United States on 29th of February, which is a Saturday, we have a large CME course. Over 120 people have already registered, and there is still room to register, so that you know that nutrition is back again. The future is already there. That means nutrition, in especially CKD, this conference, this CME course Saturday morning from 8 a.m. to 5 p.m. is all about nutritional management of CKD to avoid and defer dialysis. So for those, or mostly it's about that, but there's going to be some dialysis sessions in the afternoon. And also for those who are interested to go to China, there is another conference with the ISRNM. Please go to renalnutritionweek.org. These are sources of the presentation, including that New England Journal of Medicine paper of 2 years ago, as well as 3 textbooks, one by Dr. Ree, one by Dr. Koppel, and the other one by myself and Dr. Merotra and Dr. Gutierrez. So the answer to this question, does dialysis cause protein energy wasting, cachexia, sarcopenia, frailty? I have to say yes. Nothing is perfect. To sit down here and say dialysis is the best thing, doesn't cause anything, it's as wrong as saying chemotherapy. If you have cancer, chemotherapy is safe, don't worry, nothing happens to you. So dialysis is chemotherapy of uremia. When you have no choice, you do dialysis. And it's a great thing, it's the best thing, because patient otherwise wouldn't survive. So dialysis in careful doses is a good thing, causes also cachexia, sarcopenia, malnutrition, protein energy wasting, and all of these problems for a variety of reasons that are listed here and we can discuss. So what should we do? Is it good to have higher or lower weight if you start dialysis, or if you consider your patient on dialysis? So this is a now almost 20-year-old field, so yeah, actually, if you guys have time to say good or bad, is higher weight good or bad in dialysis patients? Is it good or is it bad? So, wow. Can you imagine somebody says higher weight is good? So, yeah, it looks like we still have bulk of majority of colleagues who say dialysis higher weight is good, so it's good to be obese and not obese. So let's move on to the next slide. So the answer to this question is these are data that have been 17-year-old in between, suggesting that while in the general population, high BMI is actually higher mortality, in dialysis patients, the higher is the BMI, the lower is mortality, and these data are so consistent, especially in hemodialysis patients. There are some questions in peritoneal dialysis patients. As to why is that, we used to call this reverse epidemiology, which is still valid when you look at lipid paradox and other paradoxes. It's called also the obesity paradox. When a patient loses weight on dialysis, that means if patient's dry weight goes lower and lower, every week that I ran on the patient have to lower dialysis, that means patient mortality goes up. When a patient loses weight, that's essentially a sign of malnutrition. And when a patient gains weights, when a patient cramps, I congratulate my patient. I say, congratulations, I can increase your dry weight. That patient lives the longest, right? All right, so now, what about frailty? It's just 1 hour talk about frailty. I'm just going to show you one slide that frailty is also related to protein energy wasting. This was a very nice review paper a number of years ago by Dr. Joel Koppel in JASN. Frailty and its definition and the concept of frailty and its close relationship with protein energy wasting in dialysis patients. Now, if higher weight is good, is it good to have more muscle or more fat? Which one is good? It turns out that fat is not bad. This is one of many studies suggesting that higher subcutaneous fat is associated with greater survival. In fact, the lowest survival was those who had less than 12% body fat using this device. So for those who go to gym and are very proud of that, their body fat is less than 12%. So still be very proud, but if you're on dialysis, think twice. Now, what about muscle? We know from these studies from France that 2/3 of dialysis patients have less than 98th percentile muscle mass. And then studies have been consistent, especially recently, that the higher is the muscle mass, any muscle you measure, be it the upper arm or intra-abdominal muscle using CT, the higher is the muscle, the lower is mortality. It's amazing. So therefore, we can say if muscle is good, fat is, if fat is good, muscle is better. So both of them are okay. Now, I can say that if your patient cannot have muscle, at least let him have fat, all right? Carefully said. Now, these are data suggesting that if you use creatinine as a muscle surrogate, you can look at some of these consistent data across different races. That means the higher is lean body mass. Lean body mass means essentially muscle and bone and viscera without fat. The higher is, the better is survival. So again, obesity paradox here, but based on lean body mass. Now, what I meant to show you here, in a study when we asked patients, how's your appetite? So I'm now linking this to nutrition. How's your appetite? Patients who said, my appetite is good during dialysis rounds, their survival was 400 times greater than patients who said, my appetite is poor. It's amazing. That single question, are you hungry? How's your appetite? Oh yes, I'm always hungry. Instead of blaming the patient for high phosphorus, congratulate the patient. Patient is the best, the healthiest, right? So just say that, be proud that you don't have anorexia. All right, that was a sarcastic joke. I'm going to move on. The prevalence of protein energy wasting on dialysis is highly common. We finally, in our society, International Society of Renal Nutrition Metabolism, we defined the so-called protein energy wasting. We tried not to call it malnutrition anymore because we said protein energy wasting is malnutrition and more, with causes and consequences. And then it starts even in earlier stages, before even dialysis starts. And dialysis starts sometimes helps, but then it continues to get worse, especially with appetite and protein intake, as you can see here. So the International Society of Renal Nutrition and Metabolism ran a meta-analysis of all data across the universe related to protein energy wasting or malnutrition in all studies related to dialysis patients, AKI patients, transplant patients, and CKD patients. And one of them, actually, I'm going to show you the data. These are where global map where the data, dialysis patient malnutrition data comes from. And some of the questions here that in the area of dialysis patients we found here, let me just show you, highlight essentially the data. And since I presented this in Mexico a number of weeks ago, I highlighted Latin America. And as you can see, the protein energy wasting or malnutrition is present in 28 to 54% of all dialysis patients, anywhere you go. And as you can see, these are data from Latin America, Europe, Asia, Western Europe, and all over the planet. So it's relatively consistent, and the link with the high prevalence of protein energy wasting / malnutrition in dialysis patients. All right, so now, do we have, going backwards through this topic, do we have tools to assess nutritional status? Well, the same society, International Society of Renal and Metabolism, came up with this with a number of criteria. So there are 4 classes of criteria. If you have 2 out of 4, your patient has protein energy wasting or malnutrition. Either a deranged serum chemistry such as albumin, and I'm going to highlight serum albumin, body mass being lower, even to the point that I said BMI less than 23 should be avoided in dialysis patients. It's unbelievable that we say below 23 is normal, we say below 23 is malnourished if patient is on dialysis. Muscle mass and dietary intake. So let's go over some of them. Albumin. Serum albumin is so dear to my heart, and dialysis organization in the US have noticed the strong association of albumin with outcomes. In the United States, at least in dialysis patients, and I can tell you everywhere you go. Now, why is that? And this question I already answered in the interest of time. I'm sorry, it says, which of the following is the strongest predictor of better survival in dialysis patient? And the answer is higher serum albumin. And it says that should serum albumin be used in a market, so there's going to be those who come to Guangzhou, China, there's going to be a debate between myself and Dr. I forgot, I think Dr. Bargman from Canada. So she's going to say albumin is useless. I'm going to say albumin is very important. So it's a hot debate. Just to watch that debate, you guys all have to come to China in April, right? All right, so look at here. When serum albumin is low, it goes from 4.2 down to 3.0. For each 0.2, mortality goes up by 100%, 50 to 100%. Just if serum albumin of your patient is instead of 3.8 is 3.6, mortality, according to this, goes up by 99% higher. Wow, that 0.1 or 0.2 is so important. So now, if you look at here, these are peritoneal dialysis patients. Peritoneal dialysis patients usually have 0.2 or 0.3 lower albumin. And that's one of the issues probably, or challenges of hemodialysis filtration. When hemodialysis filtration comes to the US, it's embarrassing that the United States is the only country left on earth where we don't have hemodialysis filtration. In fact, the average nephrologist doesn't even know what you're talking about. Those who were, if you present this debate in front of 10,000, 11,000 nephrologists, they think you're talking about IC or CC. That's where we use hemofiltration. We don't have online hemofiltration, and we're hoping that RRI, to its credit, bring it to us. So low serum albumin in hemodialysis filtration, is it bad or good? I would say that it's similar to peritoneal dialysis patients, same way that peritoneal dialysis patients' albumin is usually 0.2 or 0.3 lower than hemodialysis patients when we match in this study. Still, the higher is the better, the lower is the worse, as you can see. This is a 12,000 peritoneal dialysis cohort, one of the largest. And with the rise of twice-weekly dialysis, now that UCI model has pretty much started going all over the country and beyond and to overseas. What about twice-weekly dialysis patients? Yes, twice-weekly dialysis patients also have the same. High albumin is good, low albumin is bad, independent of residual kidney function. What about its impact on transplant? Yes, if your patients are called in for kidney transplant, if albumin is high, before transplant, that kidney transplant lasts the longest. How it's relevant or related albumin of a dialysis patient to kidney transplant survival, that's one of those interesting areas to look at. And what about patients who are transitioning to dialysis? Yes, if albumin in the last 3 months to 6 months of dialysis is higher, patients 6 months mortality in the first 6 months of dialysis is the lowest. So I have now overwhelmed you with albumin data so that you know why LDOs in the United States, they compete with each other to their credits with having who has the best highest serum albumin levels. And not only that, change in serum albumin over time, if albumin of your patient could go lower, that's bad. If it go higher, it's good. So can we change serum albumin? That's the question, right? What if somebody says albumin is low because my patient has diabetic foot ulcer and it's not malnutrition? All right, so now to make sure that we also appreciate that it's not just albumin and we have so many other things. Just one example is nutritional tools. They're screening tools, and the ISRNM, that means International Renal Nutrition Metabolism, came up already with these tables. And those are the 4 categories, and then tools to use that. One of them are called scoring systems, scoring tools. And the famous one is SGS Subjective Global Assessment with 3 categories, which is nowadays used routinely. It was refined to 7-point. It was then refined to dialysis malnutrition score, which is fully quantitative. And the latest version of this, which is now 20 years old, is malnutrition inflammation score, which is probably the most commonly used scoring system in many dialysis centers in the United States, as well as outside, as well as now in transplant centers and CKD patients. So now, going back to question, does it really matter how much your patient eats? And for those who know me, they know that I'm a strong proponent of low protein, not high protein, for CKD patients not on dialysis. But when I go in the afternoon, if I go today in the afternoon to my dialysis center to round on my 34 dialysis patients, I'm going to say the opposite. I'm going to say that protein is important. And do we measure protein intake? Yes, actually in dialysis, we are very fortunate to have NPCR, which is called also NPNA. Most of us don't even look at it. Every month it's calculated. It's right next to KT/V. There is no way you calculate KT/V without calculating NPCR. So it's there. If you look at it, it's grams of protein per kilogram body weight. And what's the distribution? As you can see here, the distribution is that half of the patients eat less than 1. KDOQI suggested, and still is going to suggest, around 1 to 1.2 grams per kilogram body weight of protein intake. That's also what is the average protein intake of the US and Western Europe protein intake. And half of dialysis patients eat less than 1, which would be okay if they were CKD, not on dialysis. I would be happy, but now this is not intentional. Does it matter? Is it associated with survival? And the answer is yes. When you look at this data, actually, it's interesting that mortality goes down up to 1.4. When a patient apparently is above 1.4, mortality goes up. This was a problem, and a lot of guidelines says don't allow dialysis patients to eat more than 1.4 grams per kilogram body weight. Now I'm going to show you 2 or 3 additional data that suggested that this 1.4 is also a confounding, and there is no limit. The more you eat, the better. The reason we have these things is because probably we didn't account for residual kidney function. Dr. Obi, who came to our center, this is just to show you not to overburden you with this equation, but this is one of the equations used for NPCR to calculate protein intake based on urea after dialysis. Urea is low, and then 44 hours before coming to the next dialysis, urea is high. The rise of urea in the patient is a surrogate of how much protein that patient ate, assuming stability across everything else, right? And we work on these equations and we adjusted them for residual kidney function, which is very important in 2020 and beyond. And what was found here is that now it's a linear association. The more your dialysis patient eats, the lower is mortality, the greater the survival, all right? So that's the message. And this is essentially very consistent. And also change is very interesting. So therefore, this slight increase in mortality after 1.3 or 1.4 doesn't exist if we adjust for residual kidney function. Therefore, encourage your dialysis patients to eat more. I pass out burgers during my dialysis rounds. And you have seen some of my tweets where I'm rounding on dialysis patients and giving 2 to 3 burgers without cheese to my dialysis patients. And in the US, they think it's a taboo, but I continue to push for that. Dialysis patients, and the first question always I ask them, how much are you hungry? Do you want food? How come you didn't bring food with you to the dialysis unit? And dialysis nurses, they don't like me because they think that I cause more problems. Now let's look at some of this data. How about this? This CJSN paper suggests that serum albumin is higher in patients who eat more protein. These are data of thousands of dialysis patients. If you look at here, the higher is protein intake, the higher is serum albumin, right? So while this is observational data, that's quite consistent with the model that people say eating more doesn't improve serum albumin. And not only that, patients who eat more, serum albumin goes higher. So again, using NPCR in thousands of patients in the United States when we modeled. This is actually, by the way, highly cited paper in CJSN, one of the highest cited paper in the past 2 years, ever since it was published 2 years ago. So in summary, high protein intake could help. What about the drawback? When you eat a lot of protein, so what are the challenges of high protein intake? High phosphorus intake, high potassium intake, high fluid intake, high likelihood of acidosis, all of the above. And the answer is, no, go back, let's do the voting. Let's see here. So one person says high phosphorus intake, and one person's actually okay. Yeah, actually just for those who are test takers, always remember when all of the above exists there, it's usually the most likely correct answer, right? Okay, now this getting corrected. So yes, high protein intake leads to not only high phosphorus, but high potassium, high fluid, worse acidosis. But for those colleagues who initially chose high phosphorus intake, I'm going to highlight, let's move on to the next slide. I'm going to highlight what you said because you're correct. When we look at the data, and I'm going to pose this question, if I go to my dialysis unit and tell the patients, don't eat this, don't eat that, it has too much phosphorus, then my patient is gonna say, doctor, is there anything left for me to eat? So I have asked all of our nephrologists and dietitians, next time you go and tell the patients don't eat this or that, try that on yourself for 2 days. You don't eat this or that and see if you can live it your life. If you can, then go back to your dialysis patient and impose all these dietary restrictions. Otherwise, don't ever tell your patient what to eat or what not to eat. So I'm sorry, I'm a little bit emotional on this. But going back to phosphorus, yes, if you eat more protein, phosphorus is high, and if you eat less phosphorus, protein is low, right? So that is the problem, already a paradox in our field, that we didn't want to talk about this. And I leave this question open, so we have a lot of data. Last questions, should we pass out meals during dialysis like Dr. Kalantar does? And the answer is yes, we have all these things. I can go over intradialytic parenteral nutrition and supplements. Supplements during dialysis. It turns out that dialysis patients who eat during dialysis, instead of being catabolic, they remain anabolic. These are data from JCI, from Dr. Ikizle's data. So the only time, that means even IDPN doesn't work as much as patients eating during dialysis or receiving supplement during dialysis. And then what's the recommended dietary protein intake? So to a dialysis patient, 0.3, 0.6, 0.9. Wow, you guys are already voting for that. So 1.1 to 1.3, above 1.5. Now, I'm just going to tell you, above 1.5, is not bad, but this is more for AKI patients. If you have AKI patients, go for it. Especially your patient is in ICU, intubated, and there are actually, we're pushing for data suggesting that high protein could even open up the kidneys while patient is in ATN. So the correct answer is 1.1 to 1.34 now. So let's move on since we have 5 minutes left, and I want to show you some data about passing out supplements during dialysis. And this is one of them suggesting serum albumin goes up, those who receive supplements. Fresenius, to its credit, used to pass out, and still do that, supplements during dialysis. And this is one of the Fresenius data suggesting that mortality of patients in dialysis in FMC units who receive supplements during dialysis was lower, right? So these are consistent data, FMC data. This is a very nice paper, AJKD, and I encourage all of you guys who would like to know more about these things to take a look. Pros and cons of eating during dialysis. Pros, everything that I said. Cons, a lot of litigations, patients choking. And I always said there was a litigation against a dialysis unit where patients were allowed to eat, and I went and the case was dismissed. I was the expert, and I said, look, if patient choke, should we stop giving food in the hospitals because patients choke? Should we starve patients to death in all hospitals? If I'm going to die when I drive a car, should I stop driving a car because there's always a risk of me getting to a fatal accident? So choking happens, 1 out of 1,000 maybe. But that doesn't mean that eating during dialysis should stop. And ISRNM also has encouraged eating during dialysis. And even there are data suggesting that the blood pressure doesn't go as low. And we have a coffee protocol. We give coffees, different types of coffees, Starbucks coffees, Jack in the Box coffees, when blood pressure is low. In fact, during dialysis. So we have coffee protocol, and we're hoping to publish some of those data that by eating and adding coffees and other drinks, you can control even blood pressure and make patients happier. All right. Is there any country where foods are being given during dialysis? I'm going to let you guys watch this. 4 years ago in Germany, actually I practiced in Germany 27 years ago, and it was the same. This is not a restaurant, this is a dialysis unit. And in Germany, to their credit, they make sure that patients who come to dialysis unit receive the 3-star or 4-star food. And that is what it should be. And these are dialysis technicians and nurses, and look what they do, right? It's amazing. I mean, dialysis patients are very happy, and they're eating, and you may say that, wow, is this low phosphorus diet? Guess what? They have orange juice, they have high potassium diet, high phosphorus diet, and they're still alive and they're doing great. Yet dietitians would probably assassinate me showing this data, right? All right, so this is Germany, not United States. And then a number of years ago, we ran this small study by giving food during dialysis. It's called Freddy's study. It was published in NDT. It's a randomized controlled trial. We gave 2 types of food during dialysis, low and high protein diet. High protein diet was given with fast renal, that means phosphorus binding. At that time, therefore, wasn't available. And it turned out that, so essentially high protein, low protein, and give a strong binder during high protein diet. And it worked extremely well. Why? Because the data showed that high protein groups, those who receive for 8 weeks high protein lunches during each dialysis, their serum albumin was higher while phosphorus didn't go as high as they thought. All right? So this paper was published 2 years ago in NDT, and it has been also highly cited, and I would like to encourage you guys to discuss it with yourself and your group when you go back. And this is the Neph Madness Twitter. At that time, visual abstract wasn't common in 2016 and 17, and they created this great young nephrologists who are very enthusiastic on tweeting. And it was also editorialized in Nature Review by Locatelli. So we're very proud of this. So finally, there was just an abstract was presented during the ASN higher serum albumin, potassium seen in patients who eat during dialysis. And I thought it's very good. So I commented about this, and you see here my smiling face, and I said that is very good. Who cares about high potassium? Go and take your potassium by potassium binders or other things. Let patients have high albumin and be happy. And finally, my last slide, in summary, measures of nutritional status correlate much more strongly than conventional risk factors with CKD mortality to the point that obesity, instead of bad, becomes good. SGA and MIS, that means subject global assessment, and malnutrition information scores are used for nutritional status, assessment of nutritional status in CKD and dialysis patients. Changes over time, that means if patients gain weight, if patient has cramps and dry weight goes up, if patient's albumin goes up, change means change in mortality. So you can change patient survival, and with that, we need studies to see if patients' happiness can change, as we had the session with Dr. Tong. And albumin remains the strongest predictor of survival, and nutritional interventions, high protein supplements and high protein meals are very promising, and we need more studies from all over the country and the world, from Mexico to Europe to Asia. I would like to acknowledge colleagues, and I would like to thank you for listening to me for the past 27 minutes. Thank you.